A very big hello to all my dear students. So today let's start with uveitis. What are the things we are going to discuss in uveitis? Let's take an overview here. Of course, what is uveitis? What are the different classifications of uveitis? What are the features of anterior, intermediate and posterior uveitis? And of course, the major chunk where the majority of the questions are asked, it is diseases associated with uveitis. So let's start. Okay, so going back to the basics, when you talk about the structure of the uveal tissue, what is the uveal tissue? It is iris, CDD body and choroid. Okay, we call it the vascular layer of your eye. I think we have done all this in our introduction chapter as well. So this is just to show you the basic anatomy. Where is retina, where is sclera? Because when you talk about posterior uveitis, we will have to talk about retinal involvement and also some retinitis or retinochoroiditis, or you can say chorioretinitis, right? So you have to know all this, right? And this is the vitreous. So when we say uveitis, what is uveitis? Very quickly, we will note it down that uveitis is inflammation of uveal tissue. It is inflammation of uveal tissue, right? Okay. How do we classify uveitis? So classification, if you talk about, I hope you're writing with me, please, and please note, make all the diagrams that I make in the class. As usual, my request is the same. So you can classify uveitis as anatomically, right? We can also classify it etiologically, or of course, we can mention it, what are the two different types, pathologically. Now, if I take from pathologically, you know pathologically we describe any uveitis as granulomatous and non-granulomatous. I won't go into the details of path here, but yes, you should know granulomatous where there is a collection of epithelioid cells, right? We get both types of nodules here if we talk about anterior uveitis, Cope's and Basaka nodule. And in non-granulomatous, we are only getting Cope's nodule. Anyway, we'll talk about it further. Coming to anatomical classification first. So, if you say anatomically, how do you divide? First is anterior uveitis. What is anterior uveitis? It is inflammation of iris and pars plicata. Because it is inflammation of iris and pars plicata, we also call it iridocyclitis. So, we are calling it iridocyclitis. Simple. Then comes intermediate uveitis. Of course, it is involvement of vitreous, peripheral retina, but mainly pars plana, and that is why we call it pars planitis. Third, what is the third part? Choroid. So, posterior uveitis, which is never always only choroiditis, it is also because retina and choroid are very close to each other, it's involvement of both. So, we call it chorioretinitis. And the fourth is your panuveitis, where all the three parts are involved, we call it panuveitis. Got it? Okay. So, here we are. I think now it's clear what is anterior, plicata and iris involvement, plana involvement is intermediate, and posterior uveitis is choroiditis with retinal involvement. Then we talk about, you can also classify it according to duration of the disease. Okay. So, according to the standardization of uveitis nomenclature, we call it SUN. So, standardization of uveitis nomenclature has also classified this as, so even the anatomical classification is by SUN and this one is also by SUN, which says that what is acute when the inflammation is less than 3 months. Nobody is going to ask you about SUN at the PG level, it is more of a PG level. Okay, this is what I mean to say. Anyway, so what is acute? Acute is when there is sudden onset, number one important part, and it is less than 3 months. So, acute is sudden onset, less than 3 months. What is chronic uveitis? More than 3 months, and it is more persistent, more than 3 months is chronic uveitis. Got it? Then we talk about what is recurrent. Recurrent means there is repeated episode, but there are inactive periods in between. That is called recurrent uveitis with inactive periods. And if there is no inflammation for more than around equal to or more than 3 months, we call it, it is remission. It is treated, right? Remission. So, when there is no activity and no inflammation in more than 3 or 3 months. more than 3 months or up to 3 months, right? So, कैसे divide किया हमने? Acute, chronic, recurrent and what is remission. Then we talk about, just remember 3 figure, you will remember everything. So, everything is around 3 months. Okay, talking about the etiological classification, it is the IUSG, that is International Uveitis Study Group, has divided it as infectious, non-infectious and masquerade. Now this again, the non-infectious can be with systemic or without systemic features, associations, with systemic association or without systemic association. We will be talking further on these headings very soon. And then we talk about is masquerade syndrome, which can be either neoplastic or non-neoplastic. So let's talk about anterior uveitis first. Anterior uveitis, of course in short we will write it as AAU, acute anterior uveitis. First important point, this is the most common form of uveitis. So when you're talking about anterior, intermediate and posterior, this is the most common form of uveitis. How will this present? Very simple, life is simple. See what I am doing, what I am making, I hope you got it. So see what I am making, you got it very quickly. Kya tha ye? These are the 5 and 6 fingers that we learned together. We have done it in the cornea chapter, in the conjunctiva chapter as well. So this is how a patient of anterior uveitis presents. That is pain, redness, photophobia. So when you say redness, I hope you remember it is a ciliary congestion. We have talked about what is ciliary congestion. These are the deeper parallel blood vessels along the limbus, right? Okay. Then we talk about photophobia. We all know what is photophobia. It is intolerance to even normal light. Then blepharospasm. Blepharo is lids. Spasm means closure of the lids. And discharge. And of course, when you're talking about anterior uveitis, we are talking about watery discharge, isn't it? So, what we get here is a watery discharge. And diminution of vision. Now, this diminution of vision can be due to any haze in the cornea or aqueous humor, or maybe some fibrosis which is interrupting the visual axis behind the lens or over the lens like occlusio pupillae, right? Anything that can lead to diminution of vision, right? We will talk about all these details further. So, on examination, let's write on examination. Of course, I am going to ask you to make a diagram here. So, all of you make a nice big diagram on examination. We just label it and we are over in my style, right? So, again make the diagram. This is the cornea, iris, right? And this is your ciliary body, pars plicata, pars plana. This is your choroid and the dotted line is the retina. This is the lens and these are the suspensory ligaments. Oversimplified diagram of course, but this makes our life simple. Now we come to one by one. First important thing is, what is the hallmark feature of anterior uveitis? So what is a hallmark feature of anterior uveitis? You answer KPs. What are KPs? Please note down. KPs are proteinaceous deposits behind the cornea. They can be fine and grey. In a non-granulomatous, you will see fine grey colored deposits on the endothelium of the cornea. This is a feature of non-granulomatous inflammations. What happens in granulomatous? In granulomatous, what we get is large KPs with greasy look, and this is what is called mutton fat KPs. So when you say mutton fat KPs, we are talking about granulomatous inflammation, right? That is the hallmark. Don't forget, this is exam question. It is a hallmark feature of anterior uveitis, right? We next talk about what is the next feature. Lot of inflammatory cells in the aqueous humor. So these inflammatory cells in the aqueous humor, what are these? These are also called aqueous cells. These inflammatory cells are called aqueous cells. So these cells in the are, again exam question, make a cue. This is the sign of active inflammation. So KPs, even when the inflammation has subsided, you may find some old KPs which are pigmented. The old KPs are generally, you can note this down also, they are typically pigmented, means even if the inflammation has subsided. But even if there is single cell also in the aqueous humor, it's a sign of active inflammation. That means inflammation is active. Got it? So we are saying it is a sign of, make a cue, active inflammation. It's a sign of active inflammation. Okay, we come to the next feature is aqueous flare. What is a flare? It's just a haziness in the anterior chamber. Do you all remember your Tyndall effect? We have learned in physics where all the small particles in the air we see moving and it will cause that haze. So, this is also happening due to this Tyndall effect. This is your aqueous flare. Now, this Tyndall effect, why it is happening? Because of leakage of, please note down as in the exam, it is leakage of proteins in the aqueous humor. Leakage? From where is it leaking? So, when you talk about leaking, let's think together. There is inflammation of iris pars pliccata, right? So, when you say inflammation of iris and pars pliccata, any inflammation is going to lead to increased capillary permeability. That is going to cause leakage. When there is a leakage in the iris, it becomes an edematous, and an edematous iris is what is called muddy iris. Similarly, there will be leakage of protein in the aqueous humor leading to aqueous flare, right? Apart from being muddy iris, what else? Of course, we will learn that we can get two types of nodules on the iris, especially in granulomatous. Okay, in granulomatous, you get to the base of the iris. The nodules are called B for B, Basaka nodule, right? This is a feature of granulomatous inflammation. And then we can also get it at the tip of the pupillary border. When you talk about the pupil and the pupillary border, before I come to this nodule, one more important point, what is the position of pupil? It is always constricted in uveitis. It is mid-dilated in angle closure glaucoma. Lot of questions have been asked on this fact. Okay, we'll remember this. So, in uveitis, it is always a constricted pupil. Why is the pupil constricted? If you want to note down, note down. I am not writing, but you can write. It is due to the effect of toxins that are released from this inflamed tissue. So, there is a spasm of the iris sphincter and the pupil is constricted. Coming back to what was the second type of nodule, the second type is your Cope's nodule. Now, the Cope's nodule can be present in both granulomatous inflammation and sometimes in non-granulomatous. Of course, if we have to choose one, we will always say granulomatous. You know, in granulomatous, the nodules are formed. Okay? Okay. What next? If nothing is being done and treated, next thing what will start happening is adhesion of the iris to the lens. And this is what is called posterior synechia. So, when the iris is adhering to the lens at the back, it is posterior synechia. When it is adhering in front with the cornea, it becomes anterior synechia. As simple. Synechia is iris adhesions. Okay. So, when iris is adhering to the lens, this is called PS here means posterior synechia. Let's make another diagram to understand better. If you talk about, if this was your iris, so this is the pupillary border, right? We are saying the synechia, so behind the iris is the lens. So, suppose this posterior synechia is formed here or here or here. So, all these are, if these are the points of adhesion, and now if you want to dilate the pupil, how will the pupil dilate? The points of adhesion will not move, rest of the pupil is dilating. This type of pupil is what is called festoon shaped pupil. Okay. So, we will not forget this term. It is asked in the exam, festoon shaped pupil. So, festoon shaped pupil means it is mainly we are talking about festoon shaped pupil is irregular pupil due to posterior synechia when we are trying to dilate. Okay. Then what will happen next? If slowly and slowly this inflammation increases, it is going to involve the whole of the pupillary border. And when it involves whole of the pupillary border, this is what is called ring synechia. What is the other name of ring synechia? We also call it seclusio pupillae. So, we also call it seclusio pupillae. Okay? So, this ring synechia seclusio pupillae which is formed, do you realize is causing total block at the pupil? Because now it is involving the whole pupillary border. Imagine the whole pupillary border adhered to the lens. Now, the aqueous cannot flow anteriorly. If the aqueous cannot flow anteriorly, there is a block here. What will happen? It will collect in the posterior chamber. And any aqueous that is collected in the posterior chamber will later lead to what? Will push the iris forward. This bowing of iris forward is what you call iris bombe, isn't it? It is B-O-M-B-E. It is iris bombe. What will happen if there is an iris bombe? It is going to now adhere to the cornea and lead to, there will be adhesion with the cornea, and this is now called peripheral anterior synechia when iris is adhering at the peripheral cornea. So, at the angle, right? So, this is what is called peripheral anterior synechia. Of course, this is going to lead to angle closure glaucoma. Any pupillary block is leading to angle closure glaucoma, isn't it? Okay, we'll see the slides also very quickly. Lastly, another very important feature. Before that, one more thing. Once this is formed, there can be one more progress, and what can happen is that instead of the pupillary border, the whole surface of the pupil that is growing on the lens surface is covered with fibrous tissue. Now we call this occlusio pupillae. Okay, this is what is occlusio pupillae. And lastly, so many of you have a confusion between what is occlusio and what is occlusio. I hope it's clear now. And later what it will lead to, of course, last feature that I wanted to mention is cyclitic membrane, which is an inflammatory membrane behind the lens. This is called cyclitic membrane. So, one diagram and you know all the features of anterior uveitis, and it's very, very important. This is one topic in the whole chapter of uveitis which will be asked in detail. So, one more thing that we can learn here is this proteinaceous cellular deposit, which are KPs. If I talk about non-granulomatous, they are mainly lymphocytes. Okay, and granulomatous mutton fat, they are mainly composed of what it is? Macrophages. Okay, we'll not forget this. So, have a look. What are these? If you will have a look, these are the large greasy KPs which are behind the cornea. This is what is called mutton fat KPs. This is what is mutton fat KPs. Do you also see this? That these KPs are mainly seen on the lower cornea and it's maximum in a triangular area. So, this maximum KPs are found in the triangular area and this is what is called Art's triangle. Okay. This is art. You know about Art's line, we learnt in trachoma. So, there are only two arts that you have to know. One is Art's triangle and one is Art's line. Right? So, now the question arises, why will the KPs be always on the lower cornea? This is a very favorite question at the MBBS level also. Of course, the major reason is due to convection current in the aqueous humor. Okay. So, because there is a convection current in the aqueous humor, it always settles down. So, one important thing you will learn is due to convection current in the aqueous humor. And secondly, what is important is number 2, some role of gravity may be there, but please don't answer only gravity, that is not correct. Mainly reason is convection current in the aqueous humor. This is the reason I am saying that the KPs are always seen on the lower cornea, right? So, here you are, these are the cells in the aqueous humor, these are aqueous cells. So, again this is your aqueous cells. And this one is your aqueous flare, okay, this is your aqueous flare. Now, what you are looking at? These are the Cope's nodules. And these at the base of the iris, it is Basaka. So, at the tip, pupillary border, it was Cope's and this is your Basaka nodule. Yes, one more feature which we haven't labeled there but we should know is there can be iris atrophy and this is typically of a viral infection or of course, we are going to read it in Fuchs heterochromic cyclitis. So, this is what is sectoral iris atrophy of herpes. We will talk about viral uveitis. And of course, the another feature in any viral infection can also be hyphema. Okay, so this can also be a feature of viral uveitis. Look at this one. These are the posterior synechia which are formed and that is the reason of this festoon shaped pupil. There is also one more question. When there is a ring synechia, imagine, go back to your diagram, if there is a ring synechia, what is the shape of anterior chamber? Okay, have a look first. These are the arrows which are telling you the site of posterior synechia, and this is your festoon shape. So my question is, if whole of this is suppose a ring synechia, do you realize the whole iris is going and adhering in the lens? The anterior chamber will be funnel shaped. Okay, they sometimes ask you, so that's why we have to know this. Make a cue here. This is in ring synechia. In ring synechia, or what do you call it? Seclusio pupillae. Right? You remember? Okay. Now I spoke about what is occlusio. When the fibrous tissue is covering this pupillary area, now this is what is called occlusio pupillae. When covering the pupillary area, this is your occlusio pupillae. Again the same story. Let's understand it again here. What it is, first of all, there is a synechia formation. This is leading to collection of the aqueous in the posterior chamber and iris bombae, right? Because of this, there will be peripheral anterior synechia and angles are closed, right? So, because of the blockage of the aqueous fluid that is blocked, right? So, this is your basic pathology or pathogenesis. Here you are, this is the iris bombae. If you see clinically, this is the bowing of iris which is so clearly seen. It's almost, this light ray is almost convex like this, isn't it? So, this is what is iris bombae. Can you see this corneal slit and the space between the iris and this is almost like it is going to adhere and leading to peripheral anterior synechia. See, there is hardly any space at the periphery. This is almost touching, isn't it? This is also touching. So, because of the iris bombae, there is a touch at the cornea and the iris, and later it can lead to adhesion formation. Of course, I can also see cataract here, isn't it? Any uveitis, I hope you can think with me this, that can lead to two major complications which you have to always remember is complicated cataract and secondary glaucoma. But if they ask you which is the most common complication, you should always answer secondary glaucoma. Okay, this is an important question. Okay, so can we note this down? Make a cue and write it, that the most common complication of anterior uveitis, we will answer is secondary glaucoma. First of all, be very clear, this you have to answer. Okay, let's see this. Yes, what is this? An inflammation can also lead to neovascularization, just like hypoxia can. Sometimes even in uveitis, you may see some rubeosus iridis. But more than that, what we learn is what is pseudo-rubeosus iridis. Too much of iris atrophy. The exposed iris blood vessels, that is what is called pseudo-rubeosus iridis. Where do you get this pseudo-rubeosus iridis? How do you differentiate it? In pseudo-rubeosus iridis, you will see these are original blood vessels, so they are more linear and straight. Here you can see these are new blood vessels and they are branched like this, right? So, this is your rubeosus iridis, but in pseudo-rubeosus iridis, it is straight. Where do you see it and why you are getting it? It is mainly due to iris atrophy, and you are getting it, which is the condition where you can see is Fuchs heterochromic cyclitis. Okay, we will be talking about it in detail. Fuchs heterochromic cyclitis. Okay. Okay. Lastly, we also have to talk about what are the IOP changes in anterior uveitis. So, if it's an acute uveitis, of course, because of either synechia formation or क्या चीज़ हो सकती है, either because of the synechia formation. Just now we talked about how a peripheral anterior synechia can lead to angle closure glaucoma. First of all, there is a pupillary block and how it leads to iris bombae, peripheral anterior synechia and angle closure glaucoma. That is one mechanism for rise in the pressures. What can be the second mechanism? Second could be any, that the inflammatory cells are, that means we are talking about aqueous cells. So, the aqueous cells are blocking the trabecular meshwork, they block the TM. Naturally, this will be an open angle glaucoma. Early this was angle closure. And what is the third? It can sometimes also lead to trabeculitis, the inflammation in the trabecular meshwork. Okay. So, these can be some causes of more pressure. What happens in chronic uveitis? In chronic uveitis, there is ciliary shutdown. When you say ciliary shutdown, what is happening? The ciliary process are forming less of the aqueous. Less aqueous means decreased intraocular pressure. Got it? So, you should know acute, what happens? More pressure. Chronic, what can happen? Less pressures. So, these are the IOP changes. right? So these were the features of anterior uveitis. So we talked about what is anterior uveitis, how will the patient present, what are the findings that we will get, right? All these findings you should be knowing it nicely. Of course, you don't have to mug up, you have to understand, right? After this, we talk about if you look at associations, what are the associations? That means the systemic associations of anterior uveitis. We just talked about etiological classification. We have to think about infectious causes, non-infectious causes, masquerade syndrome. So we are going to think in that terms only. So first we talk about is infectious causes. So talking about infectious causes, number one, if you look at the bacterial cause, one is tuberculosis, syphilis, leprosy. These three main, of course, there can be numerous. We are only talking about the ones which are very important and asked in the exams as well, right? So 1, 2, 3, tuberculosis, syphilis, leprosy, you shouldn't miss it. This is the bacterial causes of anterior uveitis. And of course, one viral cause that you have to know is, of course, we land up into herpes, herpes simplex, herpes zoster. I hope you remember now. Okay, what else? Non-infectious. When you talk about non-infectious, we will talk about number one, sarcoidosis, Behçet's disease, and HLA associated arthritis. HLA B27 associated arthritis. B27, this has been asked many times, which HLA association is arthritis associated with uveitis are. So you have to remember this HLA association, right? Okay, so ये आप non-infectious में याद रखो. What else you can add in your non-infectious apart from sarcoidosis, Behçet's and arthritis? Number 4, please add on here, we will not forget about inflammatory bowel disease. Okay, inflammatory bowel disease, mainly we are talking about ulcerative colitis or Crohn's disease, isn't it? Okay, we'll take it in detail further. Just now here we will just note down another association can be inflammatory bowel disease, ulcerative colitis or Crohn's disease. And of course, lastly, one more to complete the list is drug induced. Okay, so drug induced uveitis will also be, of course, non-infectious के अंदर ही आएगा ना. So drug induced में what are the drugs that can cause uveitis? Go back to your anti-glaucoma drugs and you'll remember we are talking about, what are we talking about? We are talking about pilocarpine can cause uveitis, prostaglandin analogs can cause uveitis, right? Sometimes some sulfonamides, but we will remember these two as major causes for aggravating or causing uveitis. ये हो गए आपके non infectious causes that we have to keep in mind, most important ones. Then we talk about masquerade syndrome. Just to complete the list here, we know this in masquerade syndrome we divide it as neoplastic and non-neoplastic. Right? Okay. Most important ones if you talk about which is relevant to you, if I can think is, do you remember in retinoblastoma you have learned that it can present as pseudo uveitis? So one of course very important is retinoblastoma, right? And then comes your of course lymphomas, malignant melanoma. In adults mainly what you get here is malignant. So all these tumors can mimic uveitis. It means only this, okay? When you're saying malignant melanoma, you mean to say mainly and involving the anterior segment, right? Which can mimic. We have to understand this, that these conditions will mimic and the picture can be like uveitis. Then we talk about, of course, and of course one more if you want to add is metastasis. Don't mug it up, just understand. And in non-neoplastic, one very important which is again relevant to us is in intraocular foreign body, okay? Intraocular foreign body may mimic as uveitis. Sometimes even the pigment dispersion syndrome that you have learnt in secondary glaucoma, PDS, that is pigment dispersion syndrome, right? So these are some very important causes that you have to keep in mind regarding anterior uveitis. Again, I am telling you, you don't have to mug up the list, just know it. We next talk about the investigations. We always divide into ocular and systemic investigations. And you all should know that investigation is actually the most important and challenging part of managing uveitis, right? So, why do I say so? Because majority of the uveitis, which if they are idiopathic, we know we have to treat it with steroids. If not steroids, of course, some immunosuppressives, right? So, treatment has to be anything around it only. isn't it? Sometimes if you know the etiological agent like tuberculosis, of course you will give ATT, syphilis, you will give penicillin and so on. What is very challenging is to find the cause of uveitis, why there is a uveitis in this patient, right? So investigation is a very, very important part of uveitis. Just know this much, that what, of course, you will be able to investigate only when you have that knowledge of what are the causes and associations of uveitis. That is why it becomes more important. When you talk about ocular, ultrasound B scan, fundus fluorescein angiography, that is FFA, and third one, so everything related to the posterior segment, we will remember, we can go for this to understand what can be the cause or associated features. Yeah, optical coherence tomography. But again, if you talk about this, ocular investigation is of use in anti-uveitis. Yes, sometimes anti-uveitis may not be only anti, it can be a pan-uveitis. You have to know and you may have to know and investigate the whole eye properly, right? To know with other parts of UV are involved or not involved. Especially for fluorescein angiography in OCT, this is more of relevance for intermediate and posterior uveitis, where we are trying to find the cystoid macular edema. Anyway, we come to the next important thing is systemic investigations. Now you have already know the causes. We are talking about syphilis, we are talking about tuberculosis. So accordingly, we are going to see that what are the tests we do. Of course, we will go for hemogram number 1. For sarcoidosis, you can go for serum AC, you can go for chest X-ray. This is more relevant for sarcoidosis. Then chest X-ray, Montague's test and quantiferon gold test for tuberculosis. We can go for VDRL or we can also go for TPHA or TPHA. This is mainly done for syphilis, right? So this way we have to think and analyze that what are the investigations we can go for. HLA typing is again very important and we have to know some HLA associations here. Important ones we are going to learn together. Let's learn it. First is your HLA B27. We have learnt already that this is your arthritis associated with uveitis, right? Second is what? We have to know about HLA B5 and HLA B51. Now both HLA B5 and HLA B51, these are associated with Behçet's disease, okay? B5 and B51, Behçet's disease. But if both are given, then we mark B5, right? And the last association that you have to know is HLA-DR4, right? So HLA-DR4 mainly is associated with, we are talking about VKH. What is VKH? Vogt-Koyanagi-Harada syndrome or sympathetic ophthalmitis. Okay? And of course, going back to if we are talking about HLA typing, mainly for arthritis, is there anything else for arthritis? Yes, we have to go for one more investigation you can note down is X-ray spine, right? Why? Because we will see that mainly ankylosing spondylitis can be one of the causes of these arthritis associated uveitis. Okay? You want to write in this list, you can write it. We will also go for X-ray spine apart from going for HLA typing. Okay? And of course, when you are saying hemogram, you have to remember apart from this, we are also talking about, we have to also go for LFT, KFT. Just to complete the list here, we have to see the glucose condition of the patient. So, go for glucose in serum and in urine, right? So, these are some important investigations. If a patient of uveitis is coming to you, we have to exclude by these investigations, of course, according to how he is presenting clinically and what are his systemic features. Okay? Okay, so we will next talk about the treatment of anterior uveitis. When you say treatment of anterior uveitis, we are talking about, there is a very important exam question here. What is the treatment of choice of anterior uveitis? We will answer topical steroids. Okay? So, treatment of choice is topical steroids. What are the steroids? Mainly we go for prednisolone. If you have to go for a mild steroids, you can go for loteprednol. And yes, one more option is difluprednate. Right. So, when treatment of choice is topical steroids and along with that what you are giving? We are also of course have to go for topical cycloplegics. Now, when you say topical cycloplegics, they have asked you what is the role of cycloplegics here. Another question. So, what is the role of cycloplegics when you are talking about in giving in anterior uveitis? Number 1, of course, we start with strongest cycloplegic, we talk about atropine. Why are you giving it? So that number one, we are paralyzing the ciliary muscles. So what will happen? It relieves the spasm. When it will relieve spasm, दो चीजें होंगी. First of all, it will enhance its blood supply, and when the blood supply is enhanced, this will have better healing due to better antibody supply, isn't it? So this is one way, one thing you have to know. Secondly, when it relieves the spasm, it relieves pain. Okay, so it will relieve pain. What is the next role? Next role is it can lead to, this was number one, A, B, right? And then number two, it can prevent posterior synechia. So mainly you have to, the purpose is to keep your pupil mobile so that adhesions won't happen. So when you say preventing posterior synechia, do you realize you have to keep the pupil mobile? So sometimes if you are keeping the patient only on atropine, it will not serve the purpose. So you should, after giving the atropine, after some while we go for shorter acting cycloplegic and mediatric like tropicacil, so that the posterior synechia is not developed. What is the third thing? Third is your breaks the posterior synechia. Breaks the posterior synechia. Of course, this can only if it is if very recent synechia is formed, you can break it. Otherwise, I have seen for the older synechias, you will not be able to break it through mediatrics, or even with the atropine, you can't break it. Okay? So that was about your role of cycloplegics. Now you already know that the steroids can have a very bad complications like complicated cataracts, it can lead to glaucoma. But here we are learning that the treatment of choice for anti-uveitis is topical steroids. Why? Because we don't have any option. If you look at the risk-benefit ratio, if you don't leave this inflammation in the eye like this, that can be even more dangerous. You got it? So, there is a study which has been going on for a long time now. They had asked you once in your exam, and that was, what is Luminate program? Right? So, what is Luminate program? So, when you say Luminate program, this is a study to find a non-steroidal treatment of uveitis. It's not only anti-uveitis, we're talking about anterior, intermediate or posterior uveitis. So, what we are trying to find? A non-steroidal treatment of uveitis, right? So, the question was, which drug are you studying? So, you will answer voclosporin. So, like cyclosporin, voclosporin is also a immunomodulator. Like cyclosporin, voclosporin is also an immunomodulator, right? Now, apart from this, of course, we have just learned that the treatment of anti-uveitis is topical steroids and topical cycloplegics. Sometimes in a chronic uveitis, which can be vision threatening, sometimes in chronic uveitis where it can be vision threatening, we can go for monoclonal antibodies, right? So, the monoclonal antibodies that you can go for is, number one, you will remember adalimumab. Okay, it's a TNF inhibitor. What is TNF? Tumor necrosis factor. And second is your infliximab. So, adalimumab or infliximab. And apart from these monoclonal antibodies, what next? One more thing that we will remember is interferon alpha. Another option can be interferon alpha. Okay? So, that was about managing anti-uveitis. Okay, so next we talk about is what is intermediate uveitis. Intermediate uveitis, we will know that it is inflammation of vitreous, that is vitritis. There is involvement of peripheral retina and of course pars plana. Peripheral most part of the retina is what? Ora serrata. After ora serrata comes pars plana. So, it is peripheral retina and pars plana, pars planitis and pars plana, right? So, we will know that this is your inflammation of vitreous, peripheral retina and pars plana is intermediate uveitis. Another point that you should know, it is a chronic disease. So, it's not acute, it's a chronic disease. So, first of all, once you know this, few points, insidious in onset. It is insidious in onset and chronic disease. Third point we will know is no gender predilection. Okay, no gender predilection. Right. So, once we know this, what is the etiology? Etiology we will again learn as infectious, non-infectious, or it can be idiopathic. When you say infectious causes, we are talking about tuberculosis, leprosy, syphilis. We also talked these etiologies in anterior uveitis, if you remember, right? So these are easy to remember. And one more protozoal infection is toxocariasis. This can also be presenting as intermediate uveitis. Coming to non-infectious, two main very important. One is sarcoidosis and second that you will know is your multiple sclerosis. Don't forget multiple sclerosis. And the third is your idiopathic. When you say idiopathic, we will know that this is mainly more than 70% of all the cases are idiopathic. And this is what is called pars planitis, right? So, this is what is pars planitis. So, ये हो गया हमारा intermediate uveitis. Next we talk about is, once you know these causes, now talking about clinical features. So, a patient of intermediate uveitis will mainly present with blurring or diminution of vision. Does it make sense? Don't mug it up. Think yourself. Which part of the uvea is being involved? The part of the uvea that is being involved is this one, isn't it? So, mainly if this part is involved, any inflammatory cells here, inflammation here, do you realize what the problem in the patient will be? It will be blurring of vision or diminution of vision. So, that is number one that you are learning. And of course, the patient can say that something is floating in front of the eyes, which are called floaters. Got it? So, can we remember this? Floaters or blurring. This is the only presenting feature. And please remember the 5 fingers here do not fit. Now, we will not talk about those fingers. Now, coming to on examination. Let's make the diagram. I've already done here. First important thing. Let's complete the diagram. This is your choroid and this is the retina. So, first important finding would be inflammatory cells behind the lens. What is this called? Retrolental flare. Right? This is number one. Number two finding, please make the diagram and label it. Few KPs. So, compared to anterior uveitis, you will get few KPs. Number three are inflammatory exudates floating in the vitreous. So, these inflammatory exudates which are floating in the vitreous, this is what is called snowballs. Okay, inflammatory exudates floating in the vitreous are snowballs, right? And when the same is actually, you will see some fibrovascular exudative plaque on the plana. This fibrovascular exudative plaque is what is called snow banking. Snow banking is what? Fibrovascular exudative plaque. Okay? So, this is very important to know here is that this is the pathognomic. Exam question hai, make a cue all of you. What is the pathognomic feature of intermediate uveitis? It is snow banking. Okay, we will not forget snow banking is the pathognomic feature of intermediate uveitis. Any other feature? Yes, when you talk about its inflammation, the intermediate uveitis can also involve the retina. It can lead to cystoid macular edema. It can lead to periphlebitis. Okay, so we will just label it here. This can lead to periphlebitis. And it can of course complicate as cystoid macular edema. Okay? So, these are the features of intermediate uveitis. Easy hai na? Retrolental flare, snowballs, snow banking, few KPs, periphlebitis. Just make the diagram. Okay. So, these are the snowballs. Of course, these circular ones are the snowballs. Okay. So, if I say this is the snowball, this is the snowballs. Okay. Floating in the vitreous. Next is this. What is this? Snow banking. That is the fibrovascular plaque on the plana. You can also have a look at snow banking here. So, this is what is snow banking. Now, why I take the slide all is I want to also show you all that when you are looking at the snow banking of the peripheral retina, you are looking by which instrument? We have discussed this. Peripheral retina we see by indirect ophthalmoscope, isn't it? So when you say indirect, what was the magnification of indirect? It was 3 times or 5 times. Such a small magnification, look at this. This is why it is such a small disc. Can you see the disc here in the macula? Such a small size, of no use. I can't see any central details here with an indirect ophthalmoscope. And now sometimes when you say snow banking, which is at the periphery of the retina and it is on the pars plana, even indirect ophthalmoscope can be a challenge to look. Then what we do is, agar indirects you are not able to see, the ideal method is, apart from indirect ophthalmoscopy, we will go for, along with that, scleral indentation. What is scleral indentation? Okay? So what we are doing? Indirect ophthalmoscopy with sclera को indent करते हैं, that is your scleral indentation. Right? So when you are indenting the sclera, actually the most peripheral part of the retina and even the pars plana wala part, that will come in picture and you will be able to see it. Again, these are the snowballs which are so nicely seen here very clearly, right? Right. We next talk about the investigations. Again, we are going to divide it as ocular and systemic. When you talk about the ocular investigations, it is the same heading, and yes, we have to know that this fluorescein angiography and OCT will help us to diagnose any associated cystoid macular edema, which can be the complication of intermediate uveitis. Right. Apart from the same systemic investigations, I will make your life simple. Instead of knowing it again and again, just know all these things the same as anterior uveitis. We are going to do everything on these investigations the same as anterior uveitis, plus one more thing that has been added is your CT MRI for brain and spine. Why? Because we want to exclude any changes of multiple sclerosis, which can also be a cause of intermediate uveitis. Got it? Okay? Okay, then we talk about the treatment part. Treatment in intermediate uveitis is a 4-step approach. Okay? So when you say 4-step approach, what are the steps? Number 1, step 1 is local steroids. But before that, one more thing. When we are talking about the step ladder approach or 4-step approach ko kya bulate hain? We can also call it step ladder approach. Right? So when you say 4-step approach or step ladder approach, before I come to the details, wanted to tell you one more thing here, that indication of treatment kya hai? Am I going to treat every patient? No. So please remember, the indication of starting the treatment is, when vision is less than 6/12. Otherwise, intermediate uveitis is considered to go for a spontaneous recovery as well. So if the vision goes that bad, actually it indicates it is causing cystoid macular edema and now something has to be done about it, and therefore we start with your treatment. And first is local steroids. How will you go for a local steroid? Either I can go for, do you all remember? I taught you all about sclera, episclera, and then what is there? Conjunctival capsule. Where was Tenon's capsule? Above the episclera. So here what we are giving? उसके बाद आता है conjunctiva, isn't it? So we give subtenon injection. So what we are giving is subtenon injection of triamcinolone acetate. TA is what? Triamcinolone acetonide. Triamcinolone acetonide. ठीक है? We are giving ठीक है? Subtenon injection of triamcinolone acetonide. The second option can be intravitreal IVTA. The same triamcinolone acetonide can be given intravitreally. This is your IVTA, right? So IVTA is intravitreal triamcinolone. IVTA is intravitreal triamcinolone acetonide. Intravitreal triamcinolone acetonide. Okay? But you know what is the main disadvantage of giving this TA intravitreally? It can cause acute rise of intraocular pressures. So there can be high rise of IOPs. We have to go for anti-glaucoma drugs along with this. If you want to avoid it, go for a slow release dexamethasone intravitreal implants. Okay? So that we can learn as the third option. If you don't want to go for this, what can be next done is intravitreally. We can go for, so we can write it like this. This is number 1, and number 2, intravitreal dexamethasone implants. Dexamethasone implants, intravitreal dexamethasone implants. Got it? So, these are slow release. So, we have to know this, because it is slow release, the increased IOP wala problem will not happen so much, right? Okay. What is the second step? The second step will be, this is your second step. If this is not working, any form of local steroids, you will go for systemic steroids. When you say systemic, what we go for is tapering doses of prednisolone. Tapering doses of prednisolone. Okay? Then what is the step 3 of the step ladder approach? It is immunosuppressives. Okay? So, this comes as step 3. Right? So, step 3 is we can go for immunosuppressives. Let's know the names. Either I go for is methotrexate. Methotrexate is given. We can go for cyclosporines. And if both are not working, apart from that, if needed, we can also go for monoclonal antibodies, right? So, monoclonal antibodies, these biological blockers may be given. Let's know the name. One is adalimumab, right? We have done this, we have learned this, and tocilizumab. It is Zumab. Right? So, adalimumab or tocilizumab. Tocilizumab is mainly given in children. Just remember this, this is mainly given in children. Okay? Okay. Earlier, this step 3 was cryo. And the cryo was mainly applied to damage the blood supply of this fibrovascular plaque, which is considered as a source of inflammation, so that the inflammation is curtailed. But it was seen that there is a lot of high incidence of retinal detachment, right? So, we have replaced it with immunosuppressives. And then lastly, if nothing works, what is the step 4? Step 4 is surgery. Step 4 is surgery, and what surgery are we talking about? We are talking about pars plana vitrectomy. It is pars plana vitrectomy. Okay? So, when you say pars plana vitrectomy, iska matlab kya hai? We are going through pars plana into the vitreous cavity and cutting the vitreous. This is what is pars plana vitrectomy. इसीलिए इसको बोलते हैं pars plana. I hope you got it, what I am trying to convey. It is going through the pars plana into the vitreous cavity and cutting the vitreous. Now, what happens? What is the benefit of this? Pars plana vitrectomy is mainly done either if there is any vitreous hemorrhage, you want to cut it in retinal detachments associated with vitreous hemorrhage, right? Or third, it can be also very important is it decreases the bulk of inflammation, isn't it? So, what happens if you are cutting all this you are doing the vitrectomy, all the inflammatory cells, snowballs, you are removing. So, the vision becomes clearer, better, blurring is less now, and it also decreases the bulk of inflammation. So, now when it decreases bulk of inflammation, your patient will respond better with the medicines. Okay. So, this is the role of surgery. Now, I told you earlier we used to go for cryo. But now it is replaced by immunosuppressives. Now, there is a modified Kaplan approach which is all about including cryo in the whole treatment regimen. So, these are 5 steps instead of 4 steps. This is called modified Kaplan approach. So, in modified Kaplan approach, first of course is local steroids, right? Then second will be your systemic steroids. Then what is third? Third is immunosuppressives. And if needed, the fourth one here is we may include cryo. Cryo is mainly cryo or laser. This is mainly done for the peripheral retina, not on the pars plana, not on the snow banking, but in the peripheral retina. And lastly, if nothing works, it is step 5, which is surgery, that is pars plana vitrectomy. Got it? So, just know this, what is modified Kaplan's approach for the treatment of intermediate uveitis, right? Okay. Let's talk about posterior uveitis now. So, when there is posterior uveitis, what did we learn? It is not only choroiditis, but it is going to involve, number 1, we are talking about choroiditis. There can be retinal involvement leading to retinitis, And of course, blood vessels are involved, both artery and vein, causing vasculitis. So, when there is an arteritis, or there can be periphlebitis. When there is a vein inflammation, what do we call it? We call it periphlebitis. So, either there is a periphlebitis or there is periarteritis, you can say. Okay. So, periarteritis is mainly it will present with hemorrhages around whatever artery is involved. And when you talk about the periphlebitis, there is typical feature of the vein. If this is the vein, how do I know this is inflamed? There will be deposition of inflammatory exudates all along this vein, and this is what is called venous sheathing. Okay. So, venous sheathing is a hallmark feature of periphlebitis, or cuffing or sheathing, whatever you want to call it. Okay, we'll keep this in mind, and this becomes a hallmark feature of periphlebitis. Okay, so these, have a look, these are the patches of choroiditis, round lesions. These are choroiditis patches. Talking about etiology, again the same headings: infectious and non-infectious causes. Infectious causes, let us again talk about this way: tuberculosis, syphilis. So, these are, learn like this with me. Bacterial causes, mainly we will learn is, so leprosy generally involves the anterior uvea, okay, majority of the times. Sometimes intermediate, but generally not posterior. But so, we generally learn TB and syphilis. Coming to viral causes, of course, both the herpes and HIV are the viral causes, and the protozoal or parasitic causes may be, we will learn it as toxocariasis and toxoplasmosis. Okay. So, these are the different causes for posterior uveitis. Okay. We come to non-infectious, very important: Weak syndrome, sarcoidosis, which is mainly a pan-uveitis. So, we are putting it everywhere in anterior, in intermediate and posterior. Then of course, we will be talking about sympathetic ophthalmitis. And what is multiple evanescent white dot syndrome? This is also written as multiple evanescent white dots in MUDES. Okay. So, this MUDES kya hai? This is not needed at our level, but yes, just remember, this is a group of diseases where you can get white dots on the fundus. Right? Okay. So, once we know this much, investigation, same heading, ocular and systemic. Ocular investigations again the same, we want to exclude the CME, right? And systemic would be same. Same headings, I am not going to repeat it again and again. Coming to treatment part. When you say the treatment, it can be local steroids, just this way we have just learned. First is local steroids, second is systemic steroids. Local, same that you have learned in intermediate uveitis. Kya padha tha? Either we are going for intravitreal injection or subtenon injection. If I give subtenon injection, I am going to give subtenon injection of triamcinolone acetate. TA is triamcinolone acetate. And if I talk about intravitreal, either I go for subtenon injection of triamcinolone acetate, but as I explained to you all, there can be marked rise of IOP. So, we can go for dexamethasone, slow release dexamethasone intravitreal. Okay. So, these are your local causes. Then we come to systemic. Systemic, I told you the tapering doses of prednisolone is the main thing that we go for. And of course, if this is not responding, we can go for immunosuppressive therapy. So, everything looks like we are repeating, isn't it? And very important is, of course, we have to manage the, let's note down number 4, we manage the etiological agent and treatment according to the etiology, isn't it? Treatment has to be according to the etiology, right? So, these are the mainly treatment modalities for posterior uveitis. Okay? So, what did you learn till now with me? See, I am making your life simple here. I told you majority of the questions will be in the part where we are talking about diseases associated with uveitis. But now I have made things easy because we know what is uveitis, we know the types of uveitis, and we know what are the features of anterior, what do we mean by granulomatous, non-granulomatous, what are the features of intermediate, and what are the features of posterior. So, suppose in any condition I tell you, okay, in this condition you get a granulomatous pan uveitis, automatically you know what are the features. If I say in this condition you get non-granulomatous anterior uveitis, again we know what we are talking about. So, every time we don't have to keep writing the details. So, it makes life easier. Now, we are going to write in boxes and point-wise about what are the different diseases associated with uveitis. Okay? Okay. So, we first take your arthritis associated with uveitis. One or two first important question they ask you is HLA association. All these are HLA B27 associated. Number 1 point. Number 2 point, they are all seronegative. When you say seronegative, it means that the rheumatoid factor is absent. Rheumatoid factor is absent. And what is the type of uveitis they all cause? In the box, all of you, non-granulomatous anterior uveitis. So, I don't need to repeat the whole features of anterior uveitis here. We know what we mean, right? So, this becomes a very quick way of learning. Okay. So, when you say this, these three things, these points, let us put a Q here. This is also exam question, this is also exam question, and this is also exam question. Now, talking about, once we know these points, what are the different arthritis? So, what are the different arthritis? We can learn it as this arthritis can either be presenting with acute anterior uveitis or it can be presenting with chronic uveitis. Which condition there is a chronic uveitis? That is called, very important all of you, juvenile rheumatoid arthritis, or its new name is juvenile idiopathic arthritis. समझ आया? And the second, of course, when you talk about anterior uveitis, we will be talking about ankylosing spondylitis, psoriatic arthritis, or Rita's syndrome. So, first of all, just know this list. Okay? So, when you say JRA or JIA, this is defined as any arthritis in less than 16 years of age. And we divide JIA into three types: posi, poly, and seismic onset. So, let us divide JRA or JIA as either it is posi-articular. When do you call posi? Matlab less. So, posi is less than equal to 4 joints. So, 4 joints or less than that is posi-articular, number 1. Number 2, polyarticular is more than 4 joints. And seismic onset, this is also called Still's disease. Here the problem starts with seismic features. Okay? Now we further learn that this polyarticular is mainly divided into type 1, which is early onset, and type 2, which is late onset. Okay? So, one is early onset, type 1 is early onset and late onset. The early onset is the one. So, what type of uveitis, what type of JRA is associated with uveitis? Not all. It's not like posi, poly. It is only type 1 posi-articular JRA which is associated with uveitis, and this is your very important repeated question. Got it? So, we will learn here it is mainly type 1 early onset posi-articular, and if I fully describe it, it will be early onset posi-articular seronegative JRA, okay, which is associated with uveitis. Seronegative JRA which is associated with uveitis. And what type of uveitis? Of course, we talked about non-granulomatous anterior uveitis. Another thing we can know here, this posi-articular early onset is more common in females and they are ANA positive, but rheumatoid factor is negative. Just remember this. Okay. I am saying that this is your non-granulomatous anterior uveitis. In JRA, of course, what did you learn with me? What is anterior uveitis? All the 5 fingers, right? Pain, redness, photophobia, this is what we expect in this patient. But in JRA, we see that typically all these are not there. It is not present. Why it is not present? We will talk about, because it's a slow smoldering inflammation. It's not that acute presentation that it's a chronic uveitis. Got it? So, no pain, no redness. When no redness, eye is white. This is the reason we call the uveitis of JRA is atypical anterior uveitis. When we say atypical, iska matlab all the 5 fingers were absent. And because it is atypical anterior uveitis and it's a chronic uveitis, of course, then this, because there is no redness, we are calling it white uveitis. Can we remember this? This is the reason The uveitis of JIA is also called white uveitis. Okay. Okay, so if we are saying it's a white uveitis, do we understand something here that if this patient has no pain, no redness, no photophobia, why will he come to you? Why will he come to me? And how will he present to the doctor? He is not going to come to the doctor in the initial stages because he has none of these problems. So, when will he present to me? Only when he has complications. So, what are the main complications that you learn? So, actually, if you talk about JIA, the patient is only presenting with complications. And what are these complications? If we talk about, the complications will be complicated cataract or secondary glaucoma. This is easy. I told you, I have mentioned this. And one more that you have to learn, you have learnt it in your corneas, band-shaped keratopathy. What was band-shaped keratopathy? Where there is calcium deposition on the cornea in form of a band. Isn't it? You remember that? So, we will remember this, and this has been your exam question, band-shaped keratopathy. Got it? Okay. So, this is how the patient will come to you and present, and of course, the treatment would be what? Treatment of course here will be manage the complication. So, just because he is presenting with complications, we have to just manage the complications. Okay? Suppose he presents with cataract and you have to operate the cataract. This exam question, will you like to put an IOL? No, IOL implantation per se is avoided. Okay? Is avoided. Why? Because it can aggravate inflammation and can lead to blinding. Can be as severe as loss of vision. Okay, so we have to be very careful because IOL is a foreign body. This patient already has a slow smoldering inflammation in the eye. So if I am putting an IOL, is it going to aggravate the inflammation? Majority of the times, yes. Easily, we will try to avoid IOL, and this is your very important exam question. See, in the whole list of your associations, that is the diseases associated with uveitis, we are going to learn two atypical anti-uveitis. This is the first one is JRA. The second we will be learning is fused heterochromic cyclitis. Keep in mind, I will talk about that again when I am taking that topic, that IOL implantation is very well tolerated in fused heterochromic cyclitis, but it is contraindicated in JRA. This has been your exam question. Okay. Okay, what are the other arthritis which is associated with acute anti-uveitis? We will be talking about, number one is your ankylosing spondylitis, Rhetus syndrome and psoriatic arthritis. You all know psoriasis is a skin disease with scaly lesions. Now, when you say Rhetus, what is the triad of Rhetus we know? Urethritis, arthritis and conjunctivitis. Actually, these are the typical triads of Rhetus, urethritis, arthritis, but of course, it also leads to uveitis and it also leads to scleritis and episcleritis, and of course, conjunctivitis we have learned. So, can we just learn all the layers? Scleritis, episcleritis, conjunctivitis and uveitis. Everything is happening in Rhetus. Also, let me add here that even in ankylosing spondylitis also you can get episcleritis, you can get scleritis and you can get, of course, you are getting uveitis here. So, all this can also be a feature of ankylosing spondylitis. Okay? And here of course, the patient is presenting as a typical case of anti-uveitis with all the 5-6 fingers. Pain, redness, photophobia, everything will be there. But yes, scleritis, episcleritis and uveitis is a feature of both ankylosing spondylitis and Rhetus. Okay. And when we talk about Rhetus syndrome, one important point, of course, it is a little extra point here, if you want to remember, that Rhetus can be triggered by these following infections: Shigella, Salmonella, Campylobacterium, या Chlamydia infections. So, it can be triggered by, so we are talking about Rhetus syndrome can be triggered by these infections. Again, as I said, it's an extra point. Right. What is the next association? We'll talk about sarcoidosis. What is sarcoidosis? We have been talking about anti-intermediate posterior every time we are writing sarcoidosis. Remember? Anyway, what is sarcoidosis? I've asked you. It is a non-caseating granulomatous inflammation involving multiple organs, and we all know it is majority of the times the lungs are predominantly involved. Okay? If you want to write, you can write it. Then coming to your eye findings, of course, what we get here, okay, you want to write it? Write out it's a non-caseating granulomatous inflammation and in the eye, what it will lead to? Of course, it is a pan-uveitis, and in the box, all of you, it is causing granulomatous pan-uveitis. Now, this has been one of your questions, so we are going to put a Q here. Apart from that, what next? Next thing is, some other features are also associated with sarcoidosis, so we make a diagram to learn it. So, let's make this diagram here. This is the plicata, the plana, and this is your choroid. This is your lens and suspensory ligaments. This becomes your dotted line is retina. Okay. So, one by one, think yourself. We have talked about sarcoidosis when we were learning about interstitial keratitis. So, one feature in the cornea is interstitial keratitis. And secondly, we have learned that because sarcoidosis there is hypercalcemia, you can get band-shaped keratopathy. Easy now? Of course, then behind the cornea, granulomatous pan-uveitis. Okay, before that, what about sclera episclera? Because the granulomatous inflammation, let's mention here, there are sarcoid nodules in the sclera and episclera. Sarcoid nodules on sclera as well as on episclera. These are again granulomatous inflammatory nodules. We call them sarcoid nodules. And because it's a pan-uveitis, and not only anterior, but it's a pan-uveitis, what you see in the retina? Of course, you will see the features of retinitis, choroiditis, that is okay. What is very, very important in exam question is, due to periphlebitis, the venous sheathing is segmental venous sheathing. So, if this is the vein, the sheathing here is segmental venous sheathing, and this is what we call candle wax drippings. This is what is candle wax drippings. So, this is your another exam question in sarcoidosis, rather repeated question, that it's straight one liner, that candle wax drippings are a feature of, you have to answer sarcoidosis. And of course, one liners are asked. Please remember this. Even if it is giving you a clinical scenario, one liners in ophthalmology, it is impossible that they don't ask you. They keep asking in every exam. Okay. Right. So, have a look. This is what is, this is the candle wax drippings, okay, of sarcoidosis. This is what is candle wax drippings that you can see of sarcoidosis. We can see some periphlebitis and changes here as well, which is around the disc, but this is also the same. Okay. Then we talk about next is, what is Lander's sign? So, what is Lander's sign? Lander's sign in sarcoidosis, just remember these are nothing but presence of pre-retinal nodules. You learnt about sarcoid nodules on the sclera and episclera. When it is pre-retinal nodule, we call it Lander's sign. Do you know what is pre-retinal? If you remember, just reminding you, this is the outermost layer of the retina, which is retinal pigment epithelium, then comes the subretinal space, then this is your layer of rods and cones, then this is external limiting membrane. Then we have learned about outer nucleus, outer plexiform, inner nucleus, inner plexiform, then ganglion cell layer, nerve fiber layer, and finally internal limiting membrane. What comes after that? We talked about your posterior hyaloid membrane of the vitreous, and this is anterior hyaloid membrane, and this becomes your anterior segment. So, the space between this, your internal limiting membrane, this is your internal limiting membrane, and the posterior hyaloid membrane of vitreous. Okay, posterior hyaloid membrane. So, this you can see the nodules in the space, and this is what is called Lander's sign. Got it? Just revise it in your retina chapter, all the details and layers of the retina. I just gave you a quick idea here what is pre-retinal space. Next we talk about is, what is Hereford syndrome? They have asked you once in your exam. We put a Q here. It is in sarcoidosis. It is uveitis with parotitis. Okay, parotid gland inflammation in sarcoidosis. This is called Hereford syndrome. Lastly, we should also have some idea about what is Lofgren syndrome, again related to sarcoidosis. So, one, there is anterior uveitis with bilateral hilar lymphadenopathy and erythema nodosum. Okay, this is again related to sarcoidosis. So, this is your Lofgren syndrome. Right. So, are we going to remember all the important questions in sarcoidosis? That is candle wax drippings, repeated question, granulomatous pan-uveitis, and of course, Hereford syndrome. We next talk about is Behçet's disease. Next heading is Behçet. What is Behçet's? Do we all know what is Behçet's? It's an obliterative vasculitis due to circulating immune complexes. And of course, remember your seismic features, that is oral ulcers, genital ulcers, positive skin test and eye involvement. Okay? So, this is what is written here. It's an obliterative vasculitis due to circulating immune complexes. These are the systemic features, and along with that there will be eye involvement. We will talk about, of course, eye involvement. So, how does it present in the eye? Now, this is a very repeated question here, that in Behçet's the main presentation is recurrent hypopyon. And because it is presenting with recurrent hypopyon, we also call it transient hypopyon syndrome. What do we call it? We call it transient hypopyon syndrome. Because it presents with recurrent hypopyon, we call it transient hypopyon syndrome. Okay, that is one important point. What was the next question which I had already discussed with you? HLA association. So, it is HLA B5 and B51. Which is more common? We will answer B5. Next. What is the type of uveitis? We put it in the box, very important. This time we will write down it's a non-granulomatous pan-uveitis. So, apart from anti-uveitis presenting with recurrent hypopyon, of course, this hypopyon is not fixed. It's a mobile hypopyon and it's happening bilateral. Okay. So, this recurrent hypopyon is seen in both eyes and it is a mobile hypopyon. You all know what is hypopyon. It's the pus cells in the anterior chamber. So, that is one thing, and if it is involving the posterior uvea, it will lead to mainly, of course, we have just said it's a vasculitis. So, posterior uvea involvement or uveitis may predominantly what we see is a vasculitis. Now, generally there is a spontaneous recovery in this case, okay. So, it keeps going, the problem keeps coming and going. So, this is your Behçet's and these are the points you have to know about Behçet's. So, here you can see this vasculitis in the Behçet's disease here, right? And here you can see the hypopyon, right? Next is, what is next association we will learn is uveitis associated with inflammatory bowel disease. We have talked about that the most common, this is important, which is most commonly involved, we will answer it is ulcerative colitis. Most common is ulcerative colitis, right? Then of course, Crohn's disease, and third we will also like to mention Whipple's disease. Okay, right. So, what is the type of uveitis? If it occurs in these conditions, we will know the type in the box, all of you. It's a non-granulomatous anterior uveitis. Okay, it's a non-granulomatous anterior uveitis, just like you have learned for arthritis. Okay. Now, ulcerative colitis, there is another question. Most common ocular feature of ulcerative colitis. Most common ocular feature of ulcerative colitis. If this is asked, now what will be your answer? You should say episcleritis. So, then we won't answer uveitis, we will answer episcleritis. So, what can be the other features? It can be episcleritis. So, if you see here, if I want to note down for ulcerative, it is episcleritis is most common. Then you can also get scleritis here. You can get conjunctivitis, right? And of course, we are getting acute anterior uveitis, right? So, these are the presentations. And of course, these are the two questions asked from this topic. Okay, next we talk about is uveitis associated with renal disease. But let's learn one line here, uveitis associated with renal disease. So again, I would say this is an extra point and hardly asked in the exam, but let's know it. It's interesting. What is TINO? So TINO is nothing but tuberointerstitial nephritis with uveitis. Okay. So this nephritis with uveitis. This is what is T. Just let us know what is the type of uveitis. It is again your non-granulomatous anterior in the box, all of you. It's bilateral non-granulomatous anterior uveitis. Typically bilateral non-granulomatous anterior uveitis. Right. We next talk about after this, and this is now very important for you all, and that is viral uveitis. So when you say viral uveitis, yeah, uveitis associated with viral infection, two main things that we will be learning is one is your HIV and second is your herpes, anti-uveitis in herpes. Okay. So when you say HIV infection, we have two main very, very important exam question. So we start with exam question. Either they can ask you is, what is the most common ocular feature? If they ask you what is the most common ocular feature, your answer is microangiopathy, pathology of small blood vessels. And if they ask you most common opportunist infection, now what is your answer? It is opportunist infection, most common is CMV retinitis. Right? Okay, this was just to start with the questions, but what are the findings in HIV infection? Ocular, of course, we are talking about ocular. First, when you say microangiopathy, let me complete this one. Microangiopathy will present as hemorrhages. It can present as microaneurysms and it can present as your cotton wool spots. So, hemorrhages, microaneurysms or cotton wool spots. There was one exam question where all three were given, then we marked cotton wool spots, okay? And microaneurysm, you all know, we have learnt it in diabetic retinopathy as well. And what is macroaneurysm? When it is more than 100 microns, it is macro, less than that is micro. Right. What can be the other features? Let's draw. So in HIV, if you think one by one, of course, first comes your lids. What are the findings in the lids? So in the lids, what we get is, of course, blepharitis and Kaposi sarcoma, isn't it? This we will not forget. So, this we will not forget. So, this is your Kaposi sarcoma on the lid. And what is the third thing that we have to remember apart from Kaposi's? Is molluscum contagium. Because the immunity is very less, you are going to get all these infections that can be presented here in an HIV patient. Contagiosum. Fine. So, here ho gaya lids. Then, let's talk about think and learn like this conjunctiva. In the conjunctiva, again, what you get is Kaposi sarcoma. And apart from that, high incidence of squamous cell carcinoma. So, let's have a look. This is what is Kaposi sarcoma of conjunctiva. Right? So, that was on conjunctiva. What else we can get? Now we can draw. Or you can just write outside this. In the lids, we have learned what we learned in the lids, what we learned in the conjunctiva. And then draw this. What about the cornea? Of course, you're going to get more incidence and more infection of, because the immunity is less, you can get simplex keratitis, you can get zoster keratitis, and of course, also your fungal keratitis. The incidence is going to be more. Make sense? And even there are these patients present with dry eye or KCS. Then we talk about the next, of course, when you talk about, there can be anti-uveitis. And on the retina, of course, we have learnt here is microangiopathy. Right? Microangiopathy. That means it's mainly a pan-uveitis and can involve from anterior to posterior, everything. We can learn this one or 2 points more here, that microangiopathy is mainly associated with low CD count. CD4 count is low. And secondly, it resolves or gets treated by its own, resolves spontaneously. Okay? Are there some other features apart from this? Yes. What about the orbit in which the eye? So, in the orbit, you can note down right here, orbit. We will learn mucormycosis. Orbital cellulitis is mainly fungal orbital cellulitis due to low immunity. So, mucormycosis. Right? And B-cell lymphomas. So, in the orbit, B-cell lymphoma and mucormycosis. Okay? Then we talk about the opportunist infections. Okay, before that, let's have a look at this one. What is this? Can you see these multiple cotton wool spots? So, we are looking at microangiopathy, HIV microangiopathy. So, these are the multiple cotton wool spots. Okay, so this is what is your HIV microangiopathy with multiple cotton wool spots. And what are we looking at here? Can you see this? This is your sauce and cheese. What is sauce and cheese? It is hemorrhage and necrosis due to CMV retinitis. And apart from this, sometimes there can be mottled appearance on the fundus, which is then called pizza pie appearance, which is not this picture exactly, okay? It's a little different. But yes, what is the main pathogenesis of pathology here is hemorrhage and necrosis due to retinitis. Okay, so when you're talking about CMV as the most common opportunist, let's see other opportunists as well. So, of course, first, we will learn is CMV. If you talk about the viral opportunist infections, we are talking about CMV retinitis. Let us learn like this, where we have just learned about sausage cheese retinopathy. And please note down a few points here that CMV retinitis is also associated with low CD4 count. Okay, it is associated with low CD4 count. One more point, the spread of the disease at the peripheral retina is along the vessels. Okay, and because it is along the vessels, we call it brush fire appearance. So, what is brush fire appearance? When the spread of the disease spreads along the blood vessels. This is what is brush fire appearance. So, this also term should be familiar to you all, along with sausage cheese retinopathy. So, in CMV retinitis, you're getting this. So, actually, we will also, if you look at the parts involved, apart from retinitis, we are also getting vitritis, and this hemorrhages, I taught you, there is arthritis or periarthritis, because of which you're getting this hemorrhage, and it can also involve optic nerve leading to optic neuritis, right? So, retinitis, arthritis, vitritis, optic neuritis, all the itis are possible in CMV retinitis infections. Okay. Okay, so once we know this, then we next talk about is apart from CMV, what is the next viral infection that you have to keep in mind? Is zoster infection due to low immunity, which can lead to acute retinal necrosis. Okay, mainly this is due to SZO. Sometimes in young patients it can be also be by simplex, but mainly we learn it by zoster. So when you say acute retinal necrosis, this is nothing but a pan-UV. Acute retinal necrosis is, you can note down in a box here, it's a pan-uveitis with peripheral retinal necrosis. Okay, pan-uveitis with peripheral retinal necrosis. Pan-uveitis with peripheral retinal necrosis. Okay? So, how will you manage? That's a viral infection. We generally go for either oral ganciclovir or valcyclovir. Treatment likho. Either oral ganciclovir or valcyclovir. Anything else? Yes, we can also go for intravitreal ganciclovir. Number 1, and second can be intravitreal ganciclovir. Apart from that, you may have to give some, under the antiviral cover, you may need to give steroids to control inflammation, but these steroids are only given under the antiviral cover. Right? So, in very severe cases, you may need to go for some steroids as well. So, this was about the two viral manifestations, opportunist infection. One is CMV and second is your acute retinal necrosis. Kya bataya tha? It is presenting as pan-uveitis with peripheral retinal necrosis. What is the next opportunist we can learn is your fungal infections. And in fungal infections, note down, one is your Pneumocystis carinii, and second we will learn it as Cryptococcus. Now, in both the cases, we should know that it is mainly causing choroiditis. So, primary involvement is what? We will learn it as choroiditis. The primary involvement here is choroiditis. And lastly, what is the third type of infection opportunist? That is your toxoplasmosis. Right? So, that means you can say protozoal infections. And in protozoal infections, it is mainly toxoplasmosis, which is also primarily causing choroiditis. Okay, so this way we can learn properly about opportunistic, whether it is viral, fungal or parasitic. Done? Okay. Coming to the treatment part, how will you manage? In case of HIV, how do we manage? Of course, we go for antiretrovirals. Now, there's a very important exam question here that if this patient is on heart therapy, highly active antiretroviral therapy, what is the most common side effect? So, what happens when you give this? When you're going to give this, the immunity gets better, right? And any immunity which gets better will manifest as inflammation. So actually the side effect of this is also uveitis, and this is called immune recovery uveitis. So we will know this is what is called immune recovery uveitis. Okay? So immune recovery uveitis is mainly involving which part of the uvea? This has been asked. It is all anterior, intermediate and posterior. But if I have to choose among all, most commonly it's a vitritis. So I will answer intermediate uveitis, primarily intermediate uveitis. Okay, but please remember all parts, you can draw it here, all parts, the IRU is involving all, it can lead to anterior uveitis, it can cause intermediate uveitis, it can cause posterior uveitis. So, immune recovery uveitis will present with all three, can present with all the three parts getting involved. Okay? So, this is one of your important exam questions. And of course, another treatment, of course, this is mainly for your this intravitreal gang cyclovir implants. So, we are talking about the opportunist infection when there is a viral infections. CMV retinitis, or we are talking about ARN. Okay? Now, what was the second part of the viral uveitis? One was HIV and second was talking about the herpes infection leading to acute anterior uveitis. Now, making your life simple, everything about the acute anterior uveitis that you have learned, clinical features are same except some plus some additional features that we have to learn only for viral. And what are those additional features? We will draw and learn together. Number one, the KPs can be stellate KPs. Number two, very, very important is, as in the exam, sectoral iris atrophy. Okay, and third important thing that we will note here is sometimes there can be hyphema, okay, blood in the anterior chamber, so it can present with hyphema. These are the three additional points that you have to remember, 1, 2 and 3, okay, and rest everything is same. And of course, when we are talking about treatment, because I know what is the etiological agent, apart from giving topical steroids, I will also go for antivirals. But I know for managing the anti-uveitis, you give topical steroids, topical cycloplegics, and apart from that, I am saying we should go for oral antivirals. Just remember this much more, right? Okay. We next talk about is bacterial uveitis. And what are the bacteria we'll be addressing to as tuberculosis, syphilis and leprosy. One by one. Let's take first is tuberculosis. Tuberculosis, again, I'll start with the same way as I started with HIV. We'll take two questions here. The questions are most common ocular feature of tuberculosis. If they ask you most common ocular feature of tuberculosis, our answer will be, all of you, uveitis. And mainly the option was given as Cope's nodules, okay? Of course, tuberculosis causes granulomatous panuveitis. It causes granulomatous panuveitis. And how do you manage it? Apart from giving the steroids, again, ATT has to be given. And under that cover only we can manage this inflammation, but otherwise steroids will be avoided. Mainly go for ATT. Second question is most common allergic manifestation. What are the allergic manifestations you have learnt with me? We have learnt about allergic manifestations that we have learnt about is, number one is your flexular conjunctivitis. What was number two? Eales disease. Yaad hai na? Eales disease is periphlebitis retini. So here what we will write, most common allergic manifestation is flexular keratoconjunctivitis. Flexular keratoconjunctivitis. Okay? Yes. So treatment, ATT. Mainly treatment will be ATT. Okay, talking about syphilis now. So syphilis, the first important point that we have to remember is that the uveitis in syphilis, which syphilis is associated with uveitis? It is a secondary infection. So we'll say secondary syphilis. Okay. What is the type of uveitis? In the box, all of you, type of uveitis. So it is not a panuveitis. Very important point to understand. This is not panuveitis. What you can get is either anterior or posterior uveitis. Posterior uveitis, you have learned with me about how it presents as salt and pepper fundus. Padha hai na? So Salt and pepper fundus, what did you learn with me? Salt and pepper fundus is when there is diffuse chorioretinitis, where the pigmentary disturbance is such that it feels as if the pepper is all around, isn't it? So this diffuse chorioretinitis is what is called salt and pepper fundus. Okay? This diffuse chorioretinitis is what is salt and pepper fundus. Okay, so once we know this, we next talk about this anterior involvement. And when you say anterior uveitis, now this anterior uveitis can either be granulomatous or it can be non-granulomatous. Either presentation is possible. Okay. So one important thing that we have to keep in mind when we are learning anterior uveitis that is asked in the exam is iris roseola. So what is iris roseola, all of you? This is your dilated capillaries which form nodule-like structure. Okay. So they are actually dilated capillaries, right? Which forms a nodule, which is forming a nodule. This is what is called iris roseola. Okay? So this can be asked, it's a feature of a direct question, you will answer syphilis. And of course, what is the treatment? We all know we will give penicillin. So you can note down the treatment will be penicillin. Okay, so the next is leprosy. This bacterial infection that we will learn is leprosy. First point in leprosy that it is the lepromatous leprosy which is associated with uveitis. Right? What does it cause? What type of uveitis? It is causing chronic granulomatous anterior uveitis. Chronic granulomatous anterior uveitis. And here what we are going to learn is iris pearls. What are iris pearls? So have a look. These are what are called iris pearls. They are actually bacterial invasions. They are composed of bacteria only. And the size is less than 0.5 mm. So iris pearls are a feature of leprosy. This is one thing you have to know, right? If we talk about the other features or ocular features of leprosy, let's make a diagram and learn other ocular features of leprosy. So in leprosy, you have learned with me at many places. Let me remind you. First of all is cause of madarosis, leprosy, right? Then we have talked about decreased, let's make a diagram, decreased corneal sensation. So cornea mein what you get is a decreased corneal sensation. You remember we learnt about viral keratoconjunctivitis, we learnt about diabetes and leprosy, isn't it? And then this is number 1, this is number 2. And of course leg ophthalmos due to 7th nerve palsy, right? So leg ophthalmos due to 7th nerve palsy, inability to close the eye. What next? Next we can write it here, granulomatous anterior uveitis. Anterior uveitis. Anything else in the cornea? Thickening of corneal nerves. This also has been done, isn't it? So we will learn thickening of corneal nerves. Okay, and what else? We can also get iris atrophy. So this is going to help, this diagram will help you to learn. And along with that, sometimes you can even get the same bacterial invasion in the retina as retinal pearls, right? So these are some of the other features of leprosy. Coming to the treatment part, of course for the systemic treatment, what we will give is dapsone, right? So systemic medication would be dapsone and rifampicin. Dapsone and rifampicin, right? And apart from that, of course, for the anterior uveitis, under the cover of these drugs, we can have to give topical steroids to control the inflammation, right? Okay. We next talk about is parasitic. So what are the two main infections that we have to know here is toxoplasmosis, which is the most common protozoal infection. Ocular, we are talking about ocular infection in adults, okay? And which is the most common in children? What we had learned, let us mention it here. This is the missing box. We will write here toxocariasis, okay? So here we will say toxocariasis. And of course, we are going to talk about onchocerciasis and one more, that is cysticercosis. But what you have to learn, most common protozoal ocular infection in adults is toxoplasmosis, and most common in children, this is toxocariasis. We are going to take the points for each one by one. First, we start with toxoplasmosis. Okay, so when you say toxoplasmosis, this is caused by, we will answer Toxoplasma gondii. Okay, caused by, full name we should know, Toxoplasma gondii. And we all know that the definitive host is the cat. And humans are the intermediate host. So, intermediate hosts are mainly the human. We are the intermediate host. Right? Okay, so once we know this, next thing that you have to, that means generally you get infected from any infection through cat feces and so on. Anyway, then we talk about is ocular feature. What does it cause in the eye? Ocular feature. So talking about the ocular features, mainly it is posterior uveitis. Okay, and the anterior uveal involvement this is only a spill. This spills into anterior uvea and that can lead to anterior uveitis. May lead to this, but mainly what it is posterior uveitis. Now, what is typical about this posterior uveitis due to toxoplasmosis? Intense vitritis. Okay, so there is such an intense vitritis. Let's make a diagram to understand that when the patient is examined and I'm looking through this intense vitritis, these choroiditis patches look very hazy. These choroiditis patches looks very hazy. Look at this one, right? And this is what is called, as you can see it here. So I will draw it again here. What we are saying that due to intense vitritis, the choroiditis patches that we see are look hazy, and this is what is, everybody knows this, double Q, headlight in fog appearance. Okay, so this is what is headlight in fog, as if I'm looking at the headlight through a fog. What is the fog here? Intense vitritis, right? So headlight in fog appearance. Okay, headlight in fog appearance. Okay, so that is one very important exam question we keep in mind. Now this toxoplasmosis mainly affects the macular area, and later what happens when it heals, that is an active stage, but when it heals, it will lead to punched out pigmented lesions. Okay, when it heals, it leads to punched out pigmented lesions, right? And let us also note down that this is predominantly, can you see this? This is the optic disc, this is the macular area. So predominantly involves the macular area. It involves commonly the macular area. We keep this in mind, okay? Hope it is clear. And yes, one more point here that this posterior uveitis can be either granulomatous or non-granulomatous. Okay, so any option can be there. Either it is non-granulomatous or granulomatous. So this is what we will remember is punched out pigmented lesions mainly at the macular area, the headlight in fog appearance. So that headlight, this choroiditis is mainly involving the macular area. This is toxoplasmosis. Let's talk about the treatment. Treatment, very important, is the triple therapy where we are giving pyrimethamine, sulfadiazine and clindamycin. And under this cover, we may need to manage with steroids. Okay, so steroids are only given under the cover of these three drugs. So given under cover when needed. Okay, this is one point. Secondly, you can also go for, we can go for intravitreal clindamycin. So another option is intravitreal clindamycin. Okay, we come to the next. Next is onchocerciasis. So we all know onchocerciasis is caused by Onchocerca volvulus. It is Onchocerca volvulus. And Onchocerca volvulus is a nematode, right? We all know this. It's a nematode. What is the other name of onchocerciasis? We also call it river blindness. Why do you call it river blindness? Because the main vector of this disease is near the river. What is that vector? Black fly, Simulian black fly. So this is mainly residing near the river, therefore we call it river blindness, right? And of course, I know this is not, you all know this, that this is not a disease of India. Mainly it is a disease of Africa, right? What does it cause in the eye? What it causes is, in the box all of you, non-granulomatous, either anterior or posterior uveitis. Non-granulomatous, either anterior or posterior uveitis, right? Now, have a look. This is onchocerciasis. These are the skin lesions. This is the corneal involvement, and the main cause of blindness in this disease is this corneal involvement. What is this called? Can you see the cornea is white just as sclera? We call it sclerosing keratitis. This is your sclerosing keratitis, right? And of course, sometimes you can see the actual worm inside the anterior chamber. So here we can see the actual worm inside the anterior chamber. So what is the main cause of blindness? We just learned sclerosing keratitis. Of course, 2020 is gone, but still we should know that it is a part of the program Vision. It was a part of program Vision 2020 because it's a blinding disease, and the main cause of blindness we have learnt is your sclerosing keratitis. Let's talk about its treatment. Treatment of onchocerciasis. So what is the treatment? What is the treatment of onchocerciasis? They can ask you the drug of choice that you will prefer. We generally give ivermectin and the purpose is solved, but we all have to know that ivermectin is only against microfilaria. It will not act against the adult worm. For the adult worm, what will you give? For the adult worm, what we give is your IV suramine. And of course, when this is happening, there will be a lot of inflammation. So we have to go for prophylactic steroid treatment, right? Prophylactic steroids are given, and these prophylactic steroids are given so that the severe reaction and inflammation is controlled. Otherwise, it can be even life-threatening. What is that called? Mazotes reaction. Okay? So, Mazotes reaction is when you are treating this condition, there is a severe inflammation and that becomes life-threatening. That is what is called Mazotes reaction. Next, we talk about is cysticercosis. We all know cysticercosis is caused by cysticercosis cellulose. Right? So, it is cysticercosis cellulose. And do we all remember this is a larva of Taenia solium. It's a larva of Taenia solium. What is mainly infecting? So, cysticercosis mainly infects, let's learn like this, it is mainly affecting the muscles, brain and the eye and the brain. Okay? We are here to learn about the ocular features. So, let's make a diagram. Talking about the ocular features, one by one, first is you can get cysts on the conjunctiva. So, conjunctival cysts, right? Second, so outside twin we learn always like that. Second is in the anterior chamber. So, you can find the cyst in the anterior chamber. Then there can be intense vitritis. And the cysts are also, the cyst or the larva can be found in the subretinal space. In the subretinal space. And of course, we are talking about muscles. So, in the extraocular muscles also you can find the cyst. So, cyst in the extraocular muscles. Now, one very important point here, which is the most common muscle involved is superior rectus. And of course, when this is happening, there will be inflammation, there is pain, and there is of course restriction of ocular movements. Pain and restriction of ocular movements. Right? So, swelling, pain and restriction of ocular movements. Right? So, this is mainly the feature of, and of course, it calcifies. So, very, very important point, it is a cause of intraocular calcification. It's a intraocular calcification. And how do you treat? We all know albendazole, but again, just we had discussed in onchocerciasis, we have to first try steroids and then, of course, albendazole, isn't it? Because if you don't do that, severe inflammation can all be life-threatening. So, we are giving albendazole, but under steroid cover, right? This time it is under steroid cover. These are the points we will remember about cysticercosis. Here it is. Can you see this? This is the conjunctival cyst. Next is toxocariasis caused by Toxocara canis. Toxocara canis is mainly roundworm in dogs. Okay, so what are the two main points that we have to remember about this toxocariasis? One, we have learnt it is the most common, this parasitic ocular infection in children. We have just mentioned it. So, more common in children. And what is the second? We have learned this in the differential diagnosis of leukocoria. Now, why do we do this? Let's see. What is toxocariasis causing? Number one, of course, there is a choroiditis patches and mainly it is causing endophthalmitis-like picture. That is why you get a white eye reflex. So, we'll make a diagram here. Clinical features, right? So, we will learn like this. It can cause anterior uveitis. It can cause intermediate. It is causing mainly endophthalmitis-like picture, right? And because of this endophthalmitis-like picture, therefore, you are getting leukocoria. And sometimes also the child can present with strabismus. And of course, posterior uveitis or chorioretinitis. Posterior uveitis, that is chorioretinitis. So, actually, if you see here, this is a pan-uveitis. Okay. So, treatment again is that is albendazole or mebendazole. Right. We next talk about is Fuchs heterochromic cyclitis. Very, very important again. Fuchs is a name. Heterochromic means difference of iris color. Okay, one by one, very important point. This is a unilateral condition. Then only you can get a heterochromia-itis. Heterochromic means there is heterochromia-itis. And what is important to know is this is mainly atypical anterior uveitis. We learnt about this. I mentioned to you that along with JRA, the other condition where you can get an atypical anterior uveitis is Fuchs heterochromic cyclitis. So, atypical anterior uveitis, and sometimes, we'll mainly learn this, but sometimes if posterior uveitis, a typical feature if the posterior uvea is also involved, because it's a very chronic inflammation, there's generally no CME seen in the posterior uveitis. Interesting fact. But again, this one is an extra point. What we will learn at our level, it is an atypical anterior uveitis, unilateral with heterochromia-itis. When you say heterochromia-itis, which eye is lighter and which eye is darker in color? Involved eye is hypochromic, which means lighter in color is the involved eye. This is hypochromic. Got it? Next we talk about is, what is the type of uveitis? Let us put it in the box. The type of uveitis is non-granulomatous chronic anterior uveitis. Okay, mainly we have to learn this only. I told you if posterior uvea, that is an extra point. We'll learn non-granulomatous anterior uveitis, which is chronic. Since it's an atypical anterior uveitis, I hope you all remember the patient is not going to complain of the 5 finger. No pain, no redness, no photophobia. This patient is only going to come with complications. Okay, so clinical features we will not say 5 fingers. Okay, the patient presents with complications, because he will not be having all these features, generally comes with complications. But of course, what are the features? What do you get here? So on examination, what we will get? On examination, generally what we are getting, of course, when the patient has none of these symptoms, he will hardly come to you, but slowly, let's see what problems he has. Number 1, he will have the KPs. Very important, these KPs are stellate KPs with feathery ends. Okay, stellate KPs with feathery ends. We talked about stellate KPs where else? In viral uveitis also we mentioned this, but please learn more for this. It is asked in your exam. Secondly, we can mark it on the diagram itself, heterochromia-itis. And thirdly, there is diffuse iris atrophy this time. And this diffuse iris atrophy that is happening can lead to pseudo-rubeosis iritis. I talked to you about it. That is exposed blood vessels. And because these blood vessels are exposed, whenever we do a paracentesis from one angle, we can get bleeding from these exposed blood vessels. And this bleeding that is happening like this is what is called Amsler's sign, right? This is important. We call it Amsler's sign. Then, of course, no posterior synechia because of the iris atrophy and also because inflammation is not that severe. We will learn here no posterior synechia. And of course, there will be complicated cataract, which is most commonly a PSC, right? It can complicate as complicated cataract or secondary glaucoma, mainly like this. One more interesting finding is iris crystals, which are called Russell bodies, can be seen. Now, this is again extra point. If you don't want to learn, it's okay. Okay, so this is Russell bodies are nothing but iris crystals. It's an extra point. It is not asked. We don't expect it to. But yes, rest of the features should be absolutely very clear to you. And because it's a mainly atypical anterior uveitis, there is no role of steroids or cycloplegics for the treatment. So this diagram will tell you everything. Okay, no role of cycloplegics or steroids. Why? Because we don't have that typical presentation. So how do you manage? We go with managing the complications, treat the cataract. And when you are treating the cataract, so when we are treating this cataract, we have to remember that IUL implantation is very much possible. We know this. This is an important exam question. And this is done in this condition. Okay. Whereas it is not or avoided in JRA. Just keep this in mind. Right. So, these are the stellate KPs. What is stellate? Mainly we are talking about star-shaped KPs. And this is your posterior subcapsular cataract. Okay. We come to the next condition. So, the next is your Vogt-Koyanagi-Harada syndrome. So, what is Vogt-Koyanagi-Harada syndrome? We should know this is an auto. So, Bo Koyanagi Harada, first of all, understand from me that these are the three names of the three scientists belonging to three different places. And this condition was simultaneously diagnosed by all three. So, the name is Bo Koyanagi Harada syndrome. Got it? That's why such a dramatic name. So, this Uveitis syndrome is an idiopathic disease which is affecting the melanocyte containing tissues like uvea, ear, and meninges. Now, we talk about the main important thing that you have to know, what it causes in the eye. So, let's make it very simple. What it causes in the eye, in the box, all of you, it's a granulomatous panuveitis along with some systemic features. Let's learn this way in my style, a little simple, okay? When you talk about the systemic features, what are those? One by one. First is your encephalitis, right? Then there can be vestibular dysfunction. Vestibular dysfunction. So then is vestibular dysfunction. What next? There can be alopecia, that is loss of hairs, vitiligo, which is white patches in the skin. Then poliosis. What is poliosis? Of course, this becomes an ocular feature where there is, this is an ocular feature where there is, we are talking about graying of eyelashes. Right? We can hold it. I'll mention it later as well. So these are the main systemic features generally seen in this patient. And this is a very quick way of learning that this is granulomatous panuveitis with these following features. This is Uveitis syndrome. Now let's elaborate. So there are 4 phases in this disease. This phase 1, if we talk about, there are 4 stages of phases. So when you talk about the 4 phases, phase 1 is mainly an prodromal phase. Now when you say prodromal phase, this is the phase where you are getting all the neurological features and auditory problems. Okay. So the neurological features and auditory features occur in the first phase. After this comes the phase 2, and this phase is an acute uveitic phase. So phase 2 is acute uveitic phase. I told you what type of uveitis it causes. Acute uveitic phase. So we know what type of uveitis it is causing. What is very important to learn that this uveitis can later complicate as it can later cause a complication, and that is because the panuveitis, it will involve the posterior uvea. It can later lead to exudative retinal detachment. Just one important point here. This is important. It can lead to exudative retinal detachment. This is important. Next phase is phase 3. Phase 3 is the convalescent phase. So in the convalescent phase, there is a lot of depigmentation that is happening. So write down convalescent phase is phase where there is a lot of depigmentation. So what are the depigmentations that can happen? One is around the limbus. This perilimbal depigmentation is what is called Segura sign. Just we will know this. This is perilimbal depigmentation. We have melanocytes here. You remember? We have learned this in the cornea also, in the limbal anatomy also. So now this is what is Segura sign. Okay. But apart from that, what else we can have is depigmentation in the choroid. And when there is a depigmentation in the choroid, this depigmentation, choroidal depigmentation, leads to sunset glow fundus. Okay. Next, it can be poliosis. This is most common. This is eyelashes. Mainly depigmentation in the eyelashes is causing poliosis. So in Uveitis, generally this is spared. Maybe this is more like a case of, the picture may not be exactly, we just took up the poliosis picture. But generally, this poliosis is only lashes. Please don't confuse, it is not the eyebrows. It may be a case of albinism maybe, if it is not an VKH. But I just wanted to show you poliosis. Okay, so we'll remember this. And of course, abhi padha tha na, vitiligo. That's another depigmentation, skin depigmentation, vitiligo. So these are the features of convalescent stage, right? So this is your poliosis. And remember vitiligo. After this, of course, this is the acute uveitic phase where I told you, you can get an exudative RD. You can see the gray reflex is all going. This is because of the exudative retinal detachment. Okay, so what is the 4th phase? 4th phase will be, I'm writing here, 4th phase is chronic recurrent phase. So in a chronic recurrent phase, you will say, what you will get is mainly it presents with anterior uveitis. So this is your phase 4. So these are the mainly 4 stages or phases of the disease, right? So a quick recap, what did we learn? 4 phases. First was prodromal with neurological. Second is acute uveitic stage where you get a granulomatous panuveitis and exudative RD. can be a complication. It's not like every time you're having, but can be a complication. Then we have the convalescent stage, and here we have learnt about Segura sign, sunset fundus, and we should also know one systemic feature as vitiligo. Of course, this is not an ocular feature. And then, of course, recurrent anterior uveitis. Okay? Now we talk about is treatment. Let's talk about the treatment. So in treatment, what we start with? We start with IV methylprednisolone. Okay? And this is bolus doses given for 3 to 5 days. And later what we will go? We will go for tapering doses of oral steroids. Of course, it's always tapering, isn't it? Right. If you think your patient is steroid resistant and is not responding, this is number one. But if it's steroid resistant, we will note down, then you will start with a biological blocker, right? And here we generally go for is, write down, if steroid resistance, we will give infliximab. Write down, if it is steroid resistant, we will give infliximab, which is a biological blocker. This is a biological blocker. Right. Okay, so coming to the last and the most important topic, this is sympathetic ophthalmitis. I think many of you know what is sympathetic ophthalmitis. There is a perforating injury in one eye which is causing uveitis in the other eye. So let us learn. The first point is after a perforating injury. Okay. And this perforating injury specifically if it is leading to iris prolapse. In that case, this patient is at a risk of having an autoimmune reaction. So what happens? The eye which is injured is called exciting eye, and so we can note this down as well, that the eye which is injured is exciting eye, is the traumatized eye, that is the injured eye, and the eye which is normal but is getting this uveitis is called sympathizing eye, right? Why? Because this was not affected, but just because of autoimmune reaction, there is a uveitis in this eye as well. So this is the reason this is uninjured eye. So this is why we call this sympathetic ophthalmitis. So why does this happen? Common sense, it's a autoimmune reaction to uveal tissue. Okay, so melanin containing tissues. It's all melanin containing tissues. So write down autoimmune reaction to the melanin containing tissues. Now this autoimmune reaction will take some time to develop. So there's a question here, after what time of injury can you get this problem? So because any autoimmunity will need at least 2 weeks to develop, we will learn this, make a cue, never before 2 weeks. Okay? And what is the majority of the chances are? It is between 2 weeks to 3 months. So majority of the times it is between 2 weeks to 3 months, the majority of the cases will present. But of course we have the cases reported even after 35 years. But this is the majority of the time, or you can say that maximum chances are between 2 weeks to 3 months. Okay, note the name of the antigen also. This is called retinal S antigen. Don't get confused, just know the name. It is retinal S antigen. It's not only in retina, of course, but we call it retinal S antigen. Okay, then we next talk about is another question. What type of, first of all, tell me what type of uveitis is this? We'll put a box and write down. It's a granulomatous panuveitis. Then next thing they will ask you, if it is a granulomatous, think with me all of you, there will be nodules. If it is granulomatous, we all know there will be nodules. Now these nodules, where are they? This is your outermost layer of the retinal pigment epithelium. What is outside the retina is choroid. So suppose this is the choroid. Okay. So there is a space, there is a membrane between the two. What is that called? That is called Bruch's membrane. Bruch's membrane is nothing but innermost layer of the choroid. We are learning all this in retina as well, right? So this is what is Bruch's membrane. Okay, so what I am trying to explain you, where are the nodules? This is your anterior segment. So nodules actually are present between these Bruch membrane and the retinal pigment epithelium. And this is what is called, this is exam question, Dehlen-Fuchs nodules. We call it Dehlen-Fuchs nodules. Okay, take it? Right. We come to the next question. What is the first sign of sympathetic ophthalmitis? This is again a repeated question. First sign is, we'll make a diagram, is retrolental flare. That means inflammatory cells are behind the lens. This is retrolental flare. So if the inflammatory cells, if this is the first sign, if this is the answer for the first sign, what will be the first symptom? So the first symptom will be corresponding to the area where it is starting. The problem is starting where? Ciliary body area. What is the prime function? Accommodation. So your first symptom, next question will be, first symptom is difficulty in near vision. Okay. So we will answer it as difficulty in near vision, or you can say decreased accommodation, or we can say decreased accommodation. Now, if this option is not given, then the next best option can be photophobia. Then we will answer photophobia. ठीक है? समझ आ गया? Right. Then another question is, what is the dangerous area of eye? So, dangerous of area of eye was a term given by Parson himself. Dangerous area of eye, we will answer is ciliary body. Why ciliary body is considered the dangerous area? Because any trauma to the ciliary body is a very big risk for sympathetic ophthalmitis. Right? Okay. Another important thing is this sunset glow fundus is sometimes also used, this term is used for this condition, sympathetic ophthalmitis. But if you have a choice, you will always prefer VKH syndrome. And why you are getting it here? There can be some chorioretinal scarring which can lead to a look like sunset glow fundus. Right? Some chorioretinal scarring is happening due to uveitis, which is leading to sunset glow fundus. So just know this, that this term can be used for both the conditions, but we prefer to answer for VKH. Okay, so what is the treatment? If I have a doubt, okay, this patient, of course, you want to repair the injury, and then you should start with high dose of steroid. If you have any risk, if you feel there's any risk of sympathetic ophthalmitis, we start with high dose of steroids, or we can even go for start with early immunosuppressives. Early start of immunosuppressives. Why you want to do this? Because we don't want this autoimmune reaction to be triggered. We want to save the other eye. And of course, for the pan uveitis, you may have to give topical steroids apart from oral, topical steroids for the anterior uveitis. For anterior uveitis. Okay? Okay, then we talk about is, if suppose the injured eye is not repairable. If it is irreparable, what next? So if the injured eye is irreparable, what we are going to go for is, we have to remove it. Why you should remove it? Because if you don't remove it, you are going to unnecessarily affect the other eye. Irreparable means there's hardly any vision, there's no vision in that eye. You don't want this patient to be completely blind. So you want to remove the eye. Once you remove the eye, what is the choice of surgery for removing the eye? Please understand that evisceration here will be contraindicated. Why is evisceration contraindicated? Because you have learned with me in the orbit chapter how evisceration, we cut the cornea, scoop out everything. While you are scooping, you will leave some iris, some uveal tissue. And whatever uveal tissue is left behind can incite an autoimmune reaction. That is why we shouldn't be doing evisceration, because it's a big risk of same autoimmune reaction. If I have to remove the eye, we go for enucleation. We will remove the whole eyeball along with the maximum part of optic. Please remember this. This is important and asked in the exam. Right? So these are the questions that are asked for sympathetic ophthalmitis. See, have a look. These are the Dalen Fuchs nodules that we were talking about. One more small thing here. What is ophthalmia nodosum? It means a very intense granulomatous inflammation with a big nodule on the iris. Okay? So this intense granulomatous inflammation, why it is happening? Granulomatous inflammation, right? Why it is happening? This term is related to which condition? This is what they ask you in the exam. And that is, this was only one question in so many years. It is due to caterpillar hair in the eye. Just let's know this, caterpillar hair in eye. Right? Okay, so now let's solve the MCQs. Anti-uveitis is most commonly associated with which systemic condition? So let's see one by one. Sarcoidosis, it is pan-uveitis, rheumatoid arthritis. Generally, all these arthritis are RA factor negative. Ankylosing spondylitis and systemic lupus. So our answer will be ankylosing spondylitis. Right? You agree with me? Okay. We come to this one. Which type of uveitis is most commonly associated with sarcoidosis? So sarcoidosis is a pan-uveitis. Granulomatous pan. Fuchs heterochromic cyclitis is most commonly associated with which clinical feature? Mutton fat KPs, vitreous hemorrhage, stellate keratic presbyrates, or retinal detachment. So we all know we are talking about stellate KPs. Which syndrome is characterized by presence of oral ulcers, genital ulcers, and uveitis, we all know we are talking about Behçet's disease, right? So that was all about uveitis. Hope you understood and enjoyed the session. Thank you so much. Stay blessed and keep smiling.